Good morning. We are going to be talking about Chapter 15, which is mental health disorders. Lots of different learning objectives. You can read through those on your own. So, approximately 60% of adolescents with depression do not receive treatment. This is so very sad. We have such a stigma around mental health illness, and mental health illness is organic in nature. And so I really hope that you all are able to help us get rid of that stigma. In the US, the ratio of suicide or attempt to suicide in adolescents is 25-1, and there's a death every 11 minutes. That is crazy to me, especially when they're completely avoidable. Mental health illness or mental illness collectively refers to mental disorders and health conditions. This can be anything that has altered their thinking, their mood, or behavior. They also have impaired functioning and distress. They may have a distorted view of self, an inability to maintain personal relationships, an inability to respond to the environment that is considered the norm, thought or behavior patterns that impair functioning and cause distress, impaired judgment, lack of insight, lots and lots of different things. Research tells us that about a half of all cases of mental illness usually is manifested with some type of symptom by the age of 14. Genetic, psychological, environment, and neurological factors all influence development of mental illness in kids. We see under genetic, we see multiple genes interacting. At this point, we really haven't found a single gene, but I do look that as we get more and more advanced that we probably will see that. Because we have learned so much in the last 5 years on all of those chemicals in our brains, as well as the chemical receptors. Major psych disorders such as depression, anxiety, schizophrenia, and bipolar are, we know, genetic. It runs in families. Autism, learning and language disorders, ADHD, and enuresis, which is bedwetting, seem to be run in families as well. Having a parent or sibling with a mental illness indicates increased risk for development of the illness. Stressful life events definitely falls under psychological influences. That can be a caregiver illness. That could be relocation, new job. I mean, it could be good changes, but they are still stressful. A marriage, a death of a family member. We see personality and temperament, how a child's temperament elicits reactions from parents. Gender, some of the different psych disorders affect males and females disproportionately. So, for instance, girls are high risk for depression, boys are high risk as ADHD. Does it mean that girls can't have ADHD or boys have depression? Absolutely not. We just know that they tend to run higher in certain genders. Age, children respond differently to events according to developmental maturity. Social and environment influences, such as parents, were they warm and supportive versus neglectful? How did they adjust to school? Was there any bullying? How's their social economic status? Are they in poverty or homelessness? Are they concerned about their next meal? What is their culture? And what that means is, how do people in their family view mental health disorders? Do they still have a really big stigma and think that it's FUPA? Religion. This can play effect into it because some religions don't believe in mental health disorders. Intrapersonal relationships. that can influence it, because if you have a positive supportive relationship, it is actually a protective factor, versus if you have poor relationships and don't have anyone you can count on, that can be very negative. Neurochemical influences, these are your norepinephrine deficiencies, and norepinephrine can cause impaired attention, problems concentrating, problems with memory, slow information processing, depressed mood, psychomotor developmental delay, fatigue. And we see, like I was talking about, Effexor in class, that's a SNRI. And when we try to give people back norepinephrine, it does give them quite a bit of energy, so just be aware they may not sleep as good. Serotonin deficiencies can cause anxiety, panic, phobia, obsessions, compulsions, food cravings, bulimia. And serotonin, you see, is the biggest drug class of medications that is given, the SSRIs. Dopamine deficiencies can cause decreased ability to experience pleasure, and that means you're just not happy, you're blah. Increased irritability and aggression, decreased cognitive functioning. And we see dopamine medicines such as like your Wellbutrin. So research shows us that the adolescent brain is still in development until they're in their 20s. We know that when they're an adolescent, the brain completely kind of rewires itself. So I find that very interesting. But you're going to do a complete mental health assessment. You're going to take into context their family, their socioeconomic status. What do they do socially? Where do they live at? What is the cultural context? You're going to do evaluation of biological, social, and psychological factors. Mental health assessments can occur in schools, primary care offices. And don't forget, like we talked about, mental health often gets worse or starts right around puberty, because they have all those hormones going crazy in their bodies and those chemical reactions, and in that brain, those chemicals are the exact same way. On your mental status examination, you're going to look specifically at language, cognitive status, emotional, and social functioning. You know, how's their appearance? How's their motor activity? Like, are they sitting here doing this or tapping their foot constantly? How's their self-concept? Do they have confidence? Do they have a negative self-concept? Do they do a lot of negative talk? Their behavior, social interaction, general intelligence, memory, and orientation. What is their attention span and comprehension, speech and language? How's their thought processes and content? How's their moods, feelings, insight, judgment? Are they having any auditory hallucinations? And that's where you hear voices that no one else hears. Are they having any visual hallucinations? That means seeing things that no one else sees. Do they have any delusional thoughts, such as thinking they're grandiose or they're the king? Do they do self-harm behaviors such as cutting themselves, banging their heads? Do they have a substance abuse problem? Have they had a sudden change in behavior? Have they had a sudden change in school performance? So lots and lots of different things. You do need to check and see if they're on any medicines, if they have any other medical problems. You need to do a suicide risk assessment. And again, when you're doing that suicide risk assessment, you do want to ask them, do you have a plan? You know, this is not going to put a plan in their head. You're not to put words in their mouth, but just by asking them, do you have a plan? If they say yes, what is your plan? What is your timeline? Again, those don't put thoughts into people's heads, but it lets people know that they just tend to, a lot of times they will tell you they're thankful someone asked them, and that way you know how serious they are. Like I said, anyone, most people at some point in their life think that they might be better off dead or might have some suicidal thoughts. What is the major red flag is if they have a plan, especially if the plan is doable. And I'm trying to think of a good example off the top of my head, but for instance, if somebody says, yes, I have a plan, I would take a gun and shoot myself. But then you say, do you have access to firearms? Because you would need to assess that if they said that. And they say, no, they don't have one and no one they know has a firearm. Well, then you know definitely they're at higher risk because they have a plan, but they don't really have the ability. However, any of that needs to be reported immediately. Then, do they have a risk of assaulting others? Do they have a history of aggression towards animals? There's some really, really big studies out that kids that torture animals later on do become sociopaths. So, you know, that's one of the things that we need to look at. Do they have a history of arson? Do they have a history of running away? How's their familial relationships? How do they get along with kids their own age? Do they participate in school events? How's their performance? Residential treatment. I'm not going to spend a lot of time on this, but you can get care in a lot of different places. From outpatient to inpatient, they typically don't have kids inpatient unless they're at a risk for themselves or to others, and then they will keep them so that they can get medication and stabilized. That's a misnomer, though. You know, as I talked in class today, typically medicines, it takes 2 to 3, actually that's early. It's going to take 4 to 6 weeks before you really start seeing a difference in them. So we don't really do it so much for depression, but more if they're a direct risk to themselves or to others. Therapeutic milieu, you do need to know this. The environment of care is called the milieu in mental health care. It is a treatment modality that provides structure and safety. The structured part of it has group therapy, community meetings, and psychoeducation. Unstructured aspects are the interactions among patients, staff, and visitors. There's a lot of collaboration with this team, which is really nice. But typically you see psychiatric nurses, nurse practitioners, clinical nurse specialists, social workers, psychologists, psychiatrists, medical doctors, OT, addiction counseling, milieu therapist, mental health worker, activity therapist. So lots of different things. Now, rules of the milieu. I find this very interesting. You're going to refer by first name only. Personal safety is a priority. They should not have any scarves, necklaces, shoelaces, belts, piercings, or anything else that they can hurt themselves or hurt somebody else. PIN numbers or a code word may be used to ensure patient confidentiality. You do not give information to anyone who does not have that PIN number or code word. I don't care what they say. You're going to check all belongings and items that come in to ensure patient and staff safety. You check each patient every 15 minutes to ensure safety. You be mindful of all items taken in. You should never give them your personal phone number or email address because, believe it or not, it does happen. During the admission process, they're going to have to change into a hospital gown. You're going to check all their belongings. You're going to remove any contraband. You're going to do a skin check. So you want to document all rashes, cuts, and scars that patient has on admission. You're going to do a full psychological and risk assessment. You're going to obtain a history and perform a physical examination. You're going to do lab tests because you want to rule out any kind of a physiological thing that could cause an acute episode of mental health. And so this is going to be CBC, comprehensive metabolic panel, TSH, thyroid stimulating hormone, because remember, if you're hyperthyroidism, that can cause some anxiety. If you're hypothyroidism, it can cause some depression. Urine and blood toxicity, UA, and pregnancy test. So, types of restrictions. Anybody that is on suicide watch, of course, is a higher risk. So you're going to frequently reassess for suicidal thoughts. They're going to wear a cloth or paper gown because they don't want the ties to be able to hang themselves. You're going to monitor that patient one-on-one. You're going to assign them a room near the nurse's station. They only get finger foods because you don't even want them to have a knife. You're going to frequently assess for signs of escalation. They're not going to have a roommate, and they're not going to be able to move off of the unit. You're going to do a lot of boundary precautions with these kiddos. You're going to watch for inappropriate verbal or physical interactions. You know, their typical daily routine: showering, cleaning up the room, making their bed, eating breakfast, group therapy, psychoeducational groups, art groups, physical activity, visiting phone calls, reflections. Lots and lots of things to help these kiddos get better. Discharge process, there's always satisfaction surveys that have to be sent out, as well as analyzed. Make sure that they have a patient safety contract. Now, if you don't know what a safety contract is, this was a really hard idea that I had to wrap my brain around. It is actually a contract between you and a patient that patient will not try to harm themselves without notifying you first. And believe it or not, they do work. And I don't know if it's just because it's written and they've signed it, but that is, you know, that is a thing. It is proven that those do work. So you're going to want to make sure that you have that. You're going to want to make sure that they have a plan for safety as well. You're going to arrange for their follow-up appointments, that they have their needed prescriptions. Use of restraints. We want to try to avoid restraints absolutely as much as possible. The only time that we use restraints is if the child is hurting himself or somebody else. And again, it is used as last resort. When applying restraints, you do have to have a physician's order. You do need to check for contraindications to the restraint, such as a physical health issue or history of abuse. Do not restrain face down. Do not restrain with arms overhead. Make sure 2 fingers can be placed in between the restraint and the limb. And you're going to recheck that circulation every 15 minutes of those extremities. You're going to pay careful attention to the respiratory status and take vital signs every 15 minutes. You're going to offer fluids and toilet every 15 minutes, range of motion every 15 minutes, and they're going to be on a one-to-one observation from a staff. And then you're going to try to discontinue these as absolutely as soon as possible, as soon as they've fallen asleep or de-escalated. And then you're going to debrief with that child later. You know, what happened to have caused this? How do we prevent this in the future? We have seclusion, and this should also be used as a last resort when the child is at risk to harm or is harming others. Do not seclude patients who have harmed themselves. If a child starts to punch or kick the wall or headbang, seclusion must be discontinued immediately. You have to have a physician's order. You check for contraindications. You take vital signs and offer fluids and toilet every 15 minutes, range of motion every 15 minutes. They need to be one-on-one observation with the staff member, and you're going to discontinue it as soon as the child is in control or fall asleep. And then again, you're going to debrief after the scenario. Psychosocial therapies can be very effective and can also be used in conjunction with medication. We sometimes will call this talk therapy, and it does help people with mental health issues to identify and change problematic thoughts and behaviors and learn effective coping skills. It is typically an effective component in treatment for a variety of mental health disorders. So the key things about kids are they don't have very good self-awareness, and they do tend to use more nonverbal communication than verbal. The goals of the therapy are going to be to improve communication skills, build self-esteem, stimulate development, build an emotional repertoire, improve emotional vocabulary, encourage assimilation of traumatic events, enable detachment from an emotional experience. Play therapy is an amazing tool to help these kiddos. Art therapy is really great about helping identify and expressing thoughts and emotions. Music therapy is wonderful to help identify and express thoughts and emotions. Pet therapy is amazing to help identify and express those. CBT, which is cognitive behavior therapy, links relationships or distorted thoughts with moods and behaviors. DBT, dialectical behavior therapy, is an intensive, high-structured therapy that addresses maladaptive learned behaviors as responses to problems. It focuses on extreme emotional instability. Tools that are used in therapy are board games, group games, recreational equipment, arts and crafts, animals, worksheets, behavior charts, timers to teach patience and impulse control, video games, relaxing music sounds, weighted vests, body socks, and visual support. And then remember that there are schools designated to help children with mental health illnesses. Kids with mental health disorders have certain rights under the American with Disabilities Act, such as non-discrimination. You see these kids with a 504 plan. And the 504 is implemented to identify accommodations needed to help the child fully participate and be successful in a program or activity at school. You can see IEP, which is individualized education plans, and these help kids be successful. Learning disabilities are neurological-based processing problems that can interfere with learning basic skills such as reading, writing, or math. They can interfere with higher level skills such as organization, time planning, abstract reasoning, long or short-term memory. They can be caused by intrauterine conditions such as maternal cigarette, alcohol, or drug use, genetics, environment factors, or it does run a lot of times with ADHD or autism. Learning disabilities are more common in boys, and about a third of students with learning disabilities also have ADHD. So nursing interventions: be patient, assess their learning needs, assess how that child best learns, design learning interventions accordingly. Teaching for caregivers of a child with a suspected or diagnosed learning disability is being an advocate. Request testing through the school. Seek help as soon as a disability is suspected, and pursue an IEP as needed. Stress is a normal part of life. Remember that there can be good stress, whether it's maybe there's a new baby in the house, or maybe the caregiver got married. Those are a lot of times good things, but it's still a stress. But then there can be some very bad things as well. Children do need to experience some stress to practice coping skills and gain confidence. Those parents that are helicopter parents that don't allow their kids to have any type of stress, that is almost as bad as too much stress. Factors that predispose kids to stress is cognitive immaturity, lack of judgment, insight, home setting, social setting, peers, events, family changes, emphasis on achievement, media influences, lots of different things. We can see manifestations of stress as physical, headaches, abdominal pain, cardiovascular disorders, GI upset, enuresis, encopresis, and that's incontinence of the stool, decreased immune functioning, so they're getting sick a lot, behavioral, acting inward, such as self-harming or overeating, acting outward, such as verbal, physical altercations, psychosocial, anxiety, depression, irritability, anger. Lots and lots of different things. Nursing strategies for stress management are, we want to encourage our patients to exercise, journal, drawing, deep breathing, meditation, hypnosis, prayer, and talking with an adult or peer. Remember, we want to find out how the child is dealing with their stressful situations, and it's not about what you expect. Things that are red flags and you need to report immediately is child is an immediate threat to self or others, talk of suicide, suicidal gestures and symptoms, interferes with relationships, or interferes with their schoolwork. A crisis is a time-limited critical incident. This can be loss of a parent, loss of a home. The four main concepts of crisis intervention is safety, catharsis, and this is patients in crisis have an overwhelming need to express their feelings. Empathy-based listening, for example, help me to understand how you're feeling. Entropy, do not add more chaos to the situation. You want to de-escalate and not escalate. Personality influences everything a person thinks, feels, and does. It's developed by age 2, which I think is awesome. Personality disorders, though, are rarely diagnosed in childhood, but a pediatric nurse should be aware of them. We have theories of personality disorders, such as psychodynamic developmental. Someone with a personality disorder is stuck in a developmental age of about 7. Cognitive behavioral behaviors are learned. Patients with personality disorders have learned maladaptive behaviors that can be improved with self-awareness and behavior modification. We have biological and genetic, and that's where we have atypical brain chemistry. So we treat these with psychopharmacology, and these often are passed down from generation to generation. Personality disorders, while adolescents can have lots of different signs and symptoms, they cannot be diagnosed until after age 18. We have borderline personality disorder, and adolescents will often have signs and symptoms of feeling as though they're bordering between sanity and psychosis. Staff splitting, which is attempting to manipulate staff to think the other staff members are not providing the best care. Self-mutilating, suicidal gestures and attempts. Affective instability, where they're shifting their mood a lot. Identity disturbance. Role absorption, which is a narrow definition of self. Painful incoherence, which is internal disharmony. Inconsistency in thoughts, feelings, and actions. Unstable personal relationships. Fears of abandonment, and often unstable, insecure attachments. Over idealized or intense relationships. Cognitive dysfunctions such as dissociation, disturbed thinking patterns, impaired problem solving, and impulsivity. Your nursing interventions: monitor for suicidal ideation, gestures, and attempts. Monitor for deliberate self-harm. Establish a routine. Be consistent. Do not let them manipulate you. Offer support. Encourage individual and group therapy. Administer antidepressants and other meds as ordered. Symptoms of impaired executive functioning are forgetfulness, distorted sense of past events, altered sense of time, altered sense of self-awareness, altered sense of future. These often run parallel with ADHD. Nursing interventions be concrete, use visual aids, reduce workload, give extended time on tests, and increase support and supervision. Attachment disorders. And the quality of the parent-child relationship is really the big indicator of future interpersonal relationships. Attachment is biologically driven and manifested by the need to touch and be close to a parental figure. Disrupted attachment occurs when the infant is unable to respond appropriately, when a caregiver does not respond appropriately, or a combination of the two. Reactive attachment disorder is characterized by the failure of a child younger than 5 to initiate or respond appropriately to caregivers. And then as a result, the caregivers have more trouble identifying and addressing the child's physical and emotional needs. Child may have diffuse attachments or indiscriminate sociability. Children at risk are those who are abused, neglected, or adopted. We have the primal wound theory of attachment, and that's where a child separated from his or her mother at birth loses the mother and sense of self because they are the same from the child's perspective. They think the child will suffer from a sense of losing oneself, and it's very hard to overcome even years later. Treatment includes assessment related to building relationships, comprehensive safety assessment, and limiting contact with non-caregiving adults to avoid non-discriminate behavior. Mood disorders are disturbances in a person's emotional state that affect daily activities. Depression is characterized by persistent sadness and loss of interest in activities. A bipolar disorder characterized by alternating periods of depression and mania. A mood disorder can be an expression of depression in kids and may manifest in infants. A sad expression or lack of expression, look away when spoken to, lack of interest in play, problem sleeping or eating. And it can be caused by separation from primary caregivers, such as like long hospitalizations or maybe substance abuse where caregivers not around a lot. Depression is huge. Your book says 7%. I disagree with that. I think it's much higher. You know, the theories of depression include faulty mood regulation of the brain, genetic vulnerability, stressful life situations, medications and medical problems. Children are less likely than adults to experience psychosis with depression. Depressed children are more likely than adults to have anxiety. Mood may be irritable rather than sad. Suicide is a real risk that peaks during mid-adolescence. Mortality from suicide increases steadily throughout the teenage years. Patients may be diagnosed with major depression, dysmic disorder, or depressive episodes. Risk factors, prior episodes of depression, family history, lack of social support, stressful life events, medical comorbidities, substance abuse. This is where you can use that sad faces. One of the biggest new trends coming out is the bully side, and that's suicide resulting from depression and hopelessness because of bullying by peers. Students who identify or perceived by others as lesbian, gay, bisexual, or transgendered are disproportionately targeted by bullies. When you know you need to start looking at medication as a child is not responding to psychotherapy, the child has severe symptoms that interferes with daily living. There's a history of recurrent depressive episodes, psychosis. Several things about medicine that we need to think about in kids is skills before pills. So skills before pills, that means that we want to always try therapy first. If we can fix something with therapy, then why medicate it? And 2 is start low, go slow. Lots of side effects, lots of problems with meds, but the benefits often are better than the risks. So just remember, start low and go slow. The effects of most psychotropic medicines are not well studied in kids. Most psychotropic drugs are used off-label and are not recommended by the FDA. Suicidal risks may increase in the initial days of treatment when first started. And in most cases, children need smaller doses of medicine spaced throughout the day. Antidepressants can take up to 2 to 4 weeks. I think that is a conservative number. I think it's a little bit longer than that. The goal of the treatment is to restore normal levels of neurotransmitters so they can act on the serotonin, the dopamine, or the norepinephrine. About 60% respond to treatment. Most have sexual side effects. These drugs do not cure depression, they reduce the symptoms. They improve motivation and psychomotor retardation before they improve the mood. So we see them antidepressants in tricyclic antidepressants, monoamine oxidase inhibitors, norepinephrine and dopamine reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors, and atypical depressants. SSRIs, the serotonin selective reuptake, is the first-line agents used to treat depression. Some of these will treat both depression and anxiety, not just depression. They have a lower risk of side effects than other classifications of the drugs. They block the reuptake of serotonin in the synaptic gap. Examples of this is fluoxetine, which is Prozac, sertraline, which is Zoloft, and escitalopram, which is Lexapro. Side effects are GI distress, sedation, anticholinergic effects, such as like your dry mouth and constipation. Think about, your anticholinergic is things like your allergy meds. That's the kind of side effects you see. Sexual dysfunction, orthostatic hypotension, in addition to serotonin syndrome and serotonin discontinuation syndrome. Serotonin syndrome is a toxidrome that results from taking too many agents that block the reuptake of serotonin. I actually had a patient die of this, so this is one of my hot topics. Not my fault that he died, but does not make it any better. So if somebody is on a medication, you need to definitely be checking signs and symptoms of serotonin syndrome is thermal dysregulation. They have trouble regulating their body temperature, confusion, agitation, fever, shivering, diaphoresis, tremor, and diarrhea. Treatment includes discontinuing one or more of the offending drugs and providing supportive care. And my particular patient that had that it wasn't a psych med. It was actually because they were on, it was a muscle relaxer. I don't remember what it was, but it was a muscle relaxer, and he smoked some dope, and that caused it. And he went to see his psychiatrist because he didn't know what was going on, and they missed it. They ended up flying him out, and he passed. And super sad situation. Remember, anything that increases or changes those chemicals in the brain can definitely make a difference in these patients. We have serotonin discontinuation syndrome. And that's when a patient suddenly stops an SSRI. They can get vertigo, feeling confused, flu-like symptoms, tremor, insomnia, agitation, anxiety, lability, and crying spells. Predictors of medication noncompliance is poor insight into symptoms, negative attitudes, substance abuse, illness, inadequate discharge. You're going to want to check for their blood pressure and monitor it, assess for suicide ideation, especially in that first month of medication administration. They may need some electroconvulsive therapy. You want to monitor for seizures. Hello. I just wanted to take a brief moment and review depression because the slides switched so quickly. One of the biggest depression scales that we use is SAD faces, SAD faces. S is for sleep disturbances. A is for anhedonia, which is your inability to experience pleasure. D is despair. F is fatigue. A is appetite changes. C is concentration. E is emotional sensitivity. And S is suicide ideation. So it's a great scale to be able to monitor that, especially for adolescents and children. We talked about with the medicine skills before, pills and start low, go slow. SSRIs, which is your selective serotonin reuptake inhibitor, are first-line agents. Don't forget, they do have less side effects. Some of the SSRIs will treat both anxiety and depression whereas some will just treat depression. Side effects are GI distress, sedation, anticholinergic effects with a dry mouth, sexual dysfunction, orthostatic hypotension, but those do typically go away within the first few weeks. Zoloft, which is one that I use in my clinical practice a lot. I'm a big fan of the Zoloft or sertraline. It can cause nightmares, so I always make sure and let patients know that, but it typically only lasts a couple of weeks. ECT, which was the electroconvulsive therapy, it is last result, and they do induce a grand mal seizure, and this enhances the dopamine sensitivity in the brain and reduces the reuptake of serotonin, and they usually get it for 3 times for 6 weeks. You are going to restrict fluids and foods for 6 to 8 hours before treatment because you don't want them to aspirate if they vomit. They typically get a muscle relaxant, and as the nurse, you're going to be doing vital signs. Bipolar, again, because that slide switched, I apologize. Bipolar is a mood disorder that has unusual shifts in mood, energy, activity levels, and ability to think clearly. So they do alternate between those periods of depression and mania. It does interfere with their daily functioning. Symptoms of being manic is feeling unusually high, euphoric, or irritable for at least 1 week. And typically we define that as feeling 10 foot tall and bulletproof. They need little sleep, and they have a great amount of energy. They talk so fast that it's difficult to follow them. They have racing thoughts. They're easily distracted. They have an inflated feeling of power, greatness, or importance. And they have reckless behavior, whether that's substance abuse, sex, money, gambling, whatever the case may be. And something to remember is that kiddos with bipolar, instead of seeing manic phases, you will often see rage because they just don't know how to express themselves. One of the big things, with bipolar is that we, give them a lot of times antipsychotics. Please remember that medication orders with XR for extended release, be cautious with medicines that have XR and ER. They are not the same as medicines without. So if you see bupropion XR or ER and then plain bupropion, it is different because the bupropion XR or ER is extended release. Lithium, this is a great mood stabilizer for bipolar. We don't really know the mechanism of action. And one of the big things you need to know about lithium is the body cannot distinguish between lithium and salt. So if the patient has increased salt intake, they're going to have a decreased lithium uptake. So they need to be on a sodium stable diet. The pathophys of lithium, though, is that it facilitates the reuptake of norepinephrine and serotonin. It leaves less of those in the synapse because they are reuptaking it. You do have to do blood levels on lithium, and norms are 0.5 to 1.2. Side effects of lithium are GI upset, weight gain, polyuria, polydipsia. It is contraindicated if they have any cardiac disease. And you're going to use very caution in patients with renal disease. So you are going to want to make sure and do a renal function. Patients can get toxic on lithium, and toxicity signs and symptoms are runny nose, cough, congestion, fever, GI upset, blurred vision, and tinnitus. Your nursing interventions with lithium is that you're going to educate family and patient on compliance. They're going to have blood levels drawn as ordered. You're going to assess for symptoms of depression and mania, and assess for suicide ideation. Medicine for pediatric bipolar and behavioral disorders, we do use Depakote and clonidine, and they're used off-label for pediatric bipolar disorder and behavior disorders. Remember that your Depakote is a anticonvulsant medication that has mood stabilizing effects. Catapress, which is your clonidine, is used for blood pressure. I haven't personally seen those used a lot. Most of the time that I've seen these used, it's due to patients getting high blood pressure, typically from other medications. However, your book is saying that you can treat some behavior disorders with it. And this is different. I know someone asked in class about Klonopin. Klonopin and clonidine are two different things. Clonidine is your Catapress, which is a blood pressure medicine. All right, moving on to anxiety disorders. These are characterized by persistent and excessive worry that interferes with daily activities. The feeling of worry can be accompanied by physical symptoms such as restlessness, irritability, fatigue, concentration problems, and insomnia. It is the most common psych disorder in kids, and separation anxiety is common in young children. Test or school-related anxiety is common in older children. You guys are not children, but I'm sure you can relate to that. And then we also need to think that, children may not be able to verbally express anxiety, so they may have psychosomatic symptoms such as headache, stomach ache, nausea, or gas. Chronic anxiety can cause decreased immune functioning where they're getting sick a lot. Cardiovascular disease, diabetes, GI issues, depression, forgetfulness, decreased attention span. So some of the nursing interventions that you can do is stay with the patient during extreme anxiety. You're going to consult with key school personnel such as teachers and administration, work with them to get a 504B plan, maintain a calm, relaxed approach, decrease environmental stimuli, encourage verbalization of feelings, encourage physical activity, teach relaxation techniques, teach problem-solving strategies, give positive feedback and support, provide psychoeducation, provide cognitive behavioral interventions. And cognitive behavioral therapy, or CBT, is huge. It is something that is extremely important, and that's definitely a skills before pills. Hypnosis is another intervention that a lot of times can really help in this. Antioxidant meds. So these antioxidant meds are your benzodiazepines, and most of these are highly addictive. They are used during crisis, but only during crisis. Hydroxyzine, which is Vistaril, and diphenhydramine, which is Benadryl, are commonly used for acute anxiety in kids. Buspirone or Buspar is long-acting antioxidant med that is non-addictive and non-sedating, and it is really a better choice. Some of the big SSRIs that can be used for anxiety is Paxil. That's probably one of my favorite, citalopram. So those are definitely out there. OCD, obsessive compulsive disorder, is characterized by severe obsessions, and this is unwanted recurring thoughts and or compulsions, which are the repetitive behaviors that interfere with the quality of life. These do create anxiety, and the compulsions are performed to reduce anxiety. A common obsession is fear of contamination with contact from germs, which can result in compulsive hand washing. We also see compulsive cleaning, checking, counting, repeating actions, ordering, making confessions, or requesting assurances. You know, you see in the movies a lot about somebody that has to check their door lock 8 or 9 times. It's a specific number for each person before that they can go to bed. Children with OCD are highly somatic because this anxiety does give them distress. It's often comorbid with personality disorders, autism, and Tourette's. The kid can experience disassociation, which is a breakdown in the functions of memory, consciousness, perception of self, environment, or sensory and motor behavior, or depersonalization, which is loss of sense of personality. Your nursing interventions, you are not going to interrupt the ritual, as this makes the child more anxious. You're going to instruct the child how to complete the stopping. So for instance, if they need to become aware of the behavior and actively try CBT therapy to try to stop them. Relaxation techniques, cue cards. Phobia is characterized by excessive anxiety brought on by exposure to a specific feared object or situation, often leading to avoidance behavior. It involves a sense of dread so intense that the individual will do everything necessary to avoid it. Common phobia are fear of the dark, fear of enclosed spaces, claustrophobia, spiders, heights, and social situations. You're going to provide support and help with anxiety management strategies such as deep breathing or distraction. Refer to cognitive behavior therapy. Panic disorders characterized by episodes of an overwhelming sense of dread and doom called panic attacks. Children often report a feeling of dizziness and faintness in addition to tachycardia and sweating. These can occur very frequently, or they can occur very infrequently. Nursing interventions, you're going to stay with the child. You're going to reassure the child that you're not going to leave. You're going to give clear directions. You're going to assist the child to an environment with minimal stimulation. And then you're going to administer any PRN antioxidant medicines. PTSD, children may develop post-traumatic stress after a traumatic event, including hospitalization for a medical condition. They can experience any elements after the initial trauma. So like the time of day, an article of clothing, a smell, or a sound can trigger a flashback. The flashback is in the limbic system of the brain, reminding the prefrontal cortex to prevent a repeat of the initial trauma. Research does show us that if they take a dose of propranolol, which is Inderal, right after a trauma, it decreases the risk for PTSD. And I find this very interesting because this is a beta blocker blood pressure medicine. But if the kid takes that right after the traumatic event, it decreases that risk for PTSD. Your nursing interventions, you're going to provide support. You're going to encourage the patient to express their feelings, refer the patient for psychotherapy, provide an antioxidant medicine after a flashback. And one of the big things for you to remember for safety, do not attempt to interact with the patient who's experiencing a flashback. If you could touch or talk to the patient, you become a part of the flashback and could be in physical danger. What theory of a personality disorder describes the patient as stuck at a developmental age of 7 years old? Is it biological or neurochemical? Is it determined or intentional? Is it cognitive or behavioral? Is it psychodynamic or developmental? The answer is D. It is psychodynamic. Developmental theory describes someone with a personality disorder that's stuck in a developmental age of about 7 years of age. Dissociative disorders are characterized by a failure to integrate identity, memory, and consciousness, and it's usually found in kids with a history of horrific abuse. It's sometimes described as an overuse and defense mechanism, and children usually report periods of loss of consciousness during which they have no memory, and this is their means of escaping reality. It's pretty easy for ages 2 through 7 because they use magical thinking to create and implement made-up friends and situations. We have different types of dissociative disorder. So we have amnesia, which is an inability to recall. We have dissociative fugue, which is unexpected travel away from home. We have depersonalization disorder, being detached from one's body. We have dissociated identity disorder, which is known as multiple personality disorders. Dissociated disorder NOS, which doesn't meet the diagnostic criteria. Interventions is going to be cognitive behavioral therapy, DPT, eye movement desensitization, reprocessing, and medications to reduce the symptoms. Disruptive disorders in kids are our ADHD, our oppositional defiant disorder, and conduct disorder. These are characterized by significant persistent behavior problems. They are also called externalizing disorders because their characteristics acting out. They're more common in school-age males, but can present in females as well. These kids are at a high risk for physical injury as a result of fighting and impulsive behaviors. Adolescents are at a high risk for sexually transmitted infections and pregnancy resulting from promiscuity. ADHD is characterized by 3 core symptoms: inattention, hyperactivity, and impulsivity. These are pervasive and inappropriate. Symptoms present both at school and at home. And the child can present as predominantly hyperactive or predominantly inactive, or they can be combined. Kids often appear to not listen when spoken to. They have difficulty following through and completing tasks. They frequently lose items necessary for tasks and are easily distractible and appear forgetful. Children who are predominantly hyperactive may be squirmy or fidgety. They run or climb inappropriately, talk excessively, interrupt, or have difficulty waiting. Discipline is frequently an issue as parents have difficulty managing disruptive behavior. And these children often show a narrow range of emotion. They have difficulty sequencing information and they have slow information processing. These symptoms can interfere with the ability to complete tasks at home and school. Nursing interventions, individual and family therapy, behavior management, providing emotional support, promoting self-esteem, and pharmacology. Medicines have a high street value. So children who do not respond to treatment may not be taking the pills. The child or caregiver can be selling them. The most common medicines are methylphenidate, which is Ritalin, amphetamines mixed with salts, which is your Adderall, your methylphenidate, which is Concerta, your Vyvanse, your Daytrana, transdermal patch, your Strattera, your guanfacine, which is 10X, which is a non-stimulant. So some of the nursing considerations: children can experience a decreased appetite and rapid weight loss from the medicines. Other side effects are insomnia, an increase in tics and compulsive behaviors, or psychotic reactions. Medications, we always need to educate the parents that they need to be given every day, regardless of whether school is in session. So what happens is caregiver or mom and dad feel like, okay, they're not in school on Saturday, Sunday, they want to give a drug vacation. which years ago we thought that was the best thing to do. But they want to give them a drug vacation. So on the weekend, the child is getting yelled at. They're not able to stay focused. It brings their self-esteem down. And then when they start back on the medicine on Monday for school, it's like a never-ending game of catch-up. So we want to tell them to give it always, or to give it every day. Things they can do at school: have the child sit next to the teacher, assign a peer helper, create a daily schedule, review previously taught material, and allow extra time. Breaking the assignments up in smaller pieces, decreasing environmental distraction, giving the child errands to run, and allowing the child to keep a set of books at home and a second set at school. Color coding folders is always good. Oppositional defiant disorder is characterized by a persistent pattern of disobedience, being argumentative, angry outbursts, low toleration for frustration, and blaming others. Of kids with ADHD, nearly 50% of them have ODD. Kids have trouble with peer and social relationships and are often in conflict. Your nursing interventions can be consistent consequences, target a few behaviors at a time, positive reinforcement with activities, and do not show emotional reactions to behavior, social skills training, caregiver training, childhood onset type, at least one symptom before age 10. Adolescent onset type is at least 3 symptoms after age 10. And they're characterized by serious violations of social norm, including aggressive behaviors, destruction of property, and cruelty. Children often engage in lying, larceny, theft, assault, and truancy, more prevalent in boys than girls. Most frequent disorder found among children residing in mental health facilities. Anxiety disorder and substance abuse are common in kids with CD. And children often present with a history of developmental delays, ADHD, and ODD. Adolescents can be hostile, sarcastic, defensive. You're going to want to provide specific feedback for desirable behavior, allow for natural consequences of action, academic support, social skills training, limit the use of group therapy, individual therapy, caregiver support, and then medicines such as your antipsychotics of haloperidol and low-dose risperidone. Mood stabilizers such as your lithium and Depakote. The key difference to remember is between oppositional defiant disorder and conduct disorder is that ODD kids feel remorseful when they break the rules or hurt someone. Children with conduct disorder do not, because they lack empathy. Impulse control, we're not going to go a lot into this. These disorders tend to develop about age of 11 years. Kleptomania is a failure to resist the urge to steal things, and they feel pleasure and relief after the theft. This is typically treated with psychotherapy, aversion therapy, SSRIs. Pyromania is intentional fire setting on more than one occasion. They get very tense before the act, and starting the fire actually gives them pleasure or gratification watching the fire. Your nursing care is going to be psychotherapy and behavior modification. Intermittent explosive disorders, that's several occurrences of failure to resist aggressive impulses that results in assaults or destruction. The aggression is out of proportion to the perceived precipitants. Nursing interventions are going to be CPT, SSRIs, antipsychotic medicines such as olanzapine, which is Zyprexa, and risperidone, which is Risperdal. Schizophrenia, though, we do want to talk about that a little bit. Childhood schizo is characterized by delusions or hallucinations, disorganized speech or behavior, and marked impairment in social or school functioning. Childhood schizo is much rarer than later onset adult schizophrenia. It is a chronic illness with periods of exacerbation and remission. They often need lifelong medication management. Causes can be genetic. It can be caused by the biochemical differences in the brain, particularly with increased dopamine or cortisol reuptake. They have increased stress levels. Youth who smoked marijuana laced with wet or formaldehyde. And guys, These kids may not know it. When they're doing any kind of drugs, it's laced with stuff that they're just not aware of. There's a FODE hypothesis, fetal origins of adult diseases. And that's where the child can develop schizophrenia because of intrauterine conditions. Patients with schizophrenia have an increased risk for cardiovascular disorders, depression, dementia, substance abuse, cigarettes, smoking. Symptoms are inappropriate affect, loss of interest or pleasure, disturbances in sleep and concentration, and loss of appetite. Delays are common in social and cognitive functioning, linguistic and motor skills. And these symptoms can be summarized with the acronym SLEPT. So S is social behavior, L is language, E is emotions, P is perception, and T is thinking. So SLEPT, remember that for your test. Effects on schizophrenia is loose association, thoughts are poorly related and are disorganized. Autism, we have autism spectrum disorder, and that's what we call pervasive developmental disorders, and have combined autism and Asperger's syndrome. It has multiple causes, including genetic, biochemical, and environmental factors. Just remember, it has severe impairment in social skills, communication, emotional attachment, or stereotype behavior. Assessments include physical, psychological, and social context. Children with ASD are more likely to be born to women 35 years and older. Deficits are usually apparent by age 18. And most of the time, the disorder is diagnosed before age 3. We have found some genetic mutations. A lot of times we see signs and symptoms of a child not talking or babbling by the age of 1 year, doesn't respond to name, doesn't seem to be able to hear, has violent tantrums, makes odd movements, does not smile, has poor eye contact, and prefers to be alone. Screening tools, the checklist of autism in toddlers, which is CHAT. The screening tool for autism in 2-year-olds, which is STAT. Nursing interventions, early intervention. The earlier you can intervene, the better chance they have. Individual and family therapy, highly structured settings, social skills, enhanced communication, behavior modification, and they may need medication. Children with ASD often have a sensory processing disorder. They're highly sensitive to sensory stimuli such as lights, noises, tactile stimulation. So lots of different things here, and the key is early intervention provides the best outcomes. Eating disorders, here we're going to talk just a little bit about anorexia and bulimia. If you remember, anorexia is where they lose their appetite or they starve themselves. They just do not eat. They're concerned that even drinking a small amount of fluid is going to cause them to gain weight. Signs and symptoms of an eating disorder is that they're hyper-focused on dieting, skipping meals, going to the bathroom after eating. You can see laxative abuse, diet pills, excessive exercise, extreme calorie counting, negative comments about self-body. There are several screening tools for eating disorders. The biggest one we use is SCOFF, S-C-O-F-F. We do put kids with anorexia in the hospital when weight reaches less than 75% of median BMI. Onset is usually early adolescence, but can occur at any age. And we do use the diagnosis anorexia for medical disorders as well, where they lose their appetite, such as like cancer with chemotherapy, dementia, where they forget to eat, things like that. Bulimia, though, is where they're causing themselves to vomit. Any of our eating disorders, they are high risk for dehydration, muscle wasting, malnutrition, electrolyte imbalances, cardiac dysrhythmias, increased risk for infection. These kids a lot of times will be on SSRIs. We will give the Propagil to stimulate the appetite. However, you do have to be careful because it can prolong the QT interval. So they do need an EKG. Some of the signs and symptoms specific to bulimia is that you see them sneaking food. They make excuses to use the bathroom after meals. They eat a large amount of foods for the moment. And again, they take laxatives, vomit, and over-exercising to purge. Enamel in their teeth begins to wear away, and that's because of the vomit. The stomach acid burns that down. You may see Russell sign. And Russell sign are teeth marks on the knuckles from self-inducing. So when you stick your fingers down your throat, it is normal that your teeth shut because your body just has that gag reflex and they know that's not supposed to go down there. So do look for the teeth marks on the back of their knuckles. Bulimia is also treated with SSRIs. We have compulsive overeating disorder, that's binge eating. They have addiction to food. They continue to eat after becoming uncomfortably food. They feel guilt, depressed afterwards. And these patients do not purge. Substance abuse, this is still continuing to skyrocket. 70% of overdoses involve opioids. Of course, we think of substance abuse as drugs, but it can also be alcohol. It can be prescription medications. And one of the big things we need to remember, and this is true with our pain medicine as well, you develop a tolerance. So after you've been taking something for a while, you no longer get that high. Or on pain medicine, you no longer get that pain control. So you build up that tolerance. So it needs more and more to get you what you need. Signs and symptoms of substance abuse: frequent absenteeism from school, work, or extracurricular activities, frequent injuries or accidents, drowsiness, slurred speech, inability or inattention to appearance, isolation, tremors, flushed face, watery red eyes, odor related to alcohol or marijuana. And so the biggest thing is we use the CAGE questionnaire for assessment, CAGE, and that's have you ever felt that you should cut down on your drinking substance abuse? Have people annoyed you by criticizing your drinking substance abuse or use? Have you felt bad or guilty about your drinking substance use? Or have you ever had to have an eye opener in the morning to steady your nerves and get rid of a hangover? 2 yes responses are suggestive of it. 3 or more yeses are diagnostic. Remember that substance abuse in the family definitely affects the child. And also, if a peer or family member uses or abuses alcohol or drugs, the child is more likely to do so. You always want to approach these situations by being non-judgmental. Do not allow yourself to be manipulated. Confront when necessary. Set those boundaries. And then you do need, most often, these are going to have drug screening by either urine, blood, or hair testing. Drug withdrawal symptoms are dependent on type of drug used, amount of drug use, their tolerance, the duration, and pre-existing psychopathology. Nursing interventions, you're going to discuss natural consequences of substance abuse. You're going to provide substance medication, education, offer hope for long-term recovery, encourage Alcoholic Anonymous, Narcotic Anonymous, encourage family therapy, develop a non-use contract with the patient, encourage independence in ADL, administer meds, and monitor side effects. And your book has a chart that's super interesting to see how long drugs stay in the system. And these are both prescription as well as recreational. But it's very important to know that. You're going to assess their vital signs, especially heart rate and blood pressure, offer group therapy. When it's alcohol, you do have to worry about DTs, as that's the most severe type of alcohol withdrawal. It typically occurs 1 week of cessation. After the cessation, can lead to visual or tactile hallucinations. They can be disoriented. They're high risk for grand mal seizures. So you do want to, encourage them to get help. You want to assess for other substances, encourage attendance at AA meetings, maintain a quiet environment, monitor vital signs, monitor for seizures, confusions. You may need to administer long-acting sedative hypnotics such as lithium, Valium, phenobarb, and Ativan. Here's some additional types of substance-related disorders, from your benzos, tobacco, vaping, caffeine, inhalants. You need to educate your patient on the warning signs of relapse and to be hypervigilant for that. Childhood abuse. Risk factors for this are high levels of stress, unstable interpersonal relationships, lack of social support, the experience of a child that is child abuse and neglect places a child at greater risk for development of psychiatric disorders later in life. You are required by law to report any suspected abuse or neglect. Again, remember, it's not up to you to determine if it happened. It's up to you to report any suspicions. Let the people that deal with this all the time determine if there's true abuse or not. Sexual abuse, you need to make sure that the evaluation is done in a safe, supportive environment. Assessment includes questions about unwanted physical or sexual contact, videos, photography, and secrecy surrounding the incident. Signs of sexual abuse are bruising, bleeding of the genitals and rectum, sexually transmitted infections, enuresis or encopresis, sexual acting out, re-traumatizing self by inserting objects into body orifices, somatic complaints, sleep difficulties, and withdrawal. Abuse can be verbal, such as calling the child names or demeaning in front of others. Munchausen syndrome by proxy is when a caregiver, usually the mother, attempts to make the child appear ill. They may put blood in the child's urine, stool, or vomit, or report made-up symptoms. So lots of different things to look at for child abuse. What nursing intervention is appropriate for a patient with OCD? And that's interrupt the child's ritual to slow increasing anxiety, instruct the child on how to complete thought stopping, refer to CPT, reassure the child that you will, I can't tell what that last one said. The correct answer is B. You're not going to interrupt that ritual, as this makes the child more anxious. You're going to instruct the child on how to complete the stopping, and that's where the child becomes aware of their thoughts and tries to stop them. Relaxation techniques and cue cards. All right, I'm going to get this sent out, and if you all have any questions, please do not hesitate to let me know. Have a good day.